Hi, Jean Marie. It's Cord. How are you?
Say it again.
Can you
Oh, I
hear?
said, good, Court. How are you?
I'm doing good. Thanks. I'm testing out the audio and video on my end too. So thank you.
No, that's good. We need a test. Hi, good afternoon, everybody. Can you guys hear everything okay?
Yes.
Okay, well, welcome to our fourth meeting of our work group. Before we start, we're going to take a quick roll call. In the room with me is Ann Sabignano, Julie Beard, and Stacy Howes. Next, we have Senator Pam Beidel, Delegate Tom Hutchinson, Delegate Ken Kerr.
I'm here.
Hello. Lisa Simpson, Peggy Shimoda from the Hospice and Palliative Care Network.
Here.
Hi, Peggy.
Hi.
Hi, Monica Escalante.
I'm here.
Hi, Monica.
Hello.
Cord Kastner from Hospice Analytics.
Hi, I'm here too.
Great. Catherine Hamill from Gilchrist. Rebecca Miller from Hospice of the Chesapeake. Okay. Lee Chambers from Medicaid.
Leah's here.
Hi, Leah. Carlos Graveron
Good
from
afternoon,
LifeBridge.
everyone.
Hi, Carlos. Carrie Craig. Stephen Farrow.
I'm here.
Hello. Oksana Linkova. Tammy Rossback from MedStar. Yeah, I think Tammy said she wasn't going to be able to join, but I did invite Patrick from Bayada to join. Patrick, are you there?
I am here. Great to be here.
Thank you for joining last minute to represent home health. We appreciate it. Tina Simmons.
I'm here.
Hi, Tina. Brandon Rose.
Good afternoon.
Hi, Brandon. Amanda Wright.
I'm here.
Sarah McKay.
I'm here.
Hello. Dana Kaufman.
I saw her.
Yes, her too.
Sorry.
Okay. And
Here.
hi, Dana. And Heather Guerreri.
Here.
Hi, Heather.
Hi.
I think
And we're getting a lot of feedback. If you're not speaking, can you put yourself on mute, please?
okay. As Stacy said, make sure that you have your cell phones on mute when you're not speaking. Other reminders, no substantive comments in the chat, and please introduce yourself before speaking. Another reminder that all of the materials for all of these meetings are on the commission website, but let Stacy or I know if you are unable to access something. And lastly, we want to let you know that we are videotaping this as well as taking notes with Gemini AI. Okay, next slide.
Second. Are you able to see the presentation?
Mhm.
Are you seeing the presentation?
Are you
Yes.
guys, you can see it?
Small though.
Okay.
It's just a small.
What am I doing? Just 1 second. Sorry, guys, I'm having trouble getting this into presentation mode. We might just skip that part and leave it not in presentation mode and move forward. Okay. Go ahead.
So, okay, next slide.
I'm not seeing any.
Yeah, I know,
slides right
I know,
now.
I know,
Okay.
I know. Hold on.
Okay, now it's up.
Okay, where do you want to go?
Next slide.
This one?
Okay, perfect. So sorry about that. Our work group plan, you guys can see that we had 4 meetings scheduled. We are at the 4th and final meeting, which is today, August 18th. When Stacy and I, when we were planning for the work group, we came to present to the hospice network, and the feedback that we got was that we were focused on what we needed to do for the health plan and for the methodology. But the hospice industry really wanted to talk about also what was important to them. So things like utilization. And so that's what this meeting is for today. It's really a meeting for you guys to have those conversations. We've tried to facilitate that with having members here from the state, from Medicaid, from HSCRC, from the nursing home industry, from home health, from the hospital industry. So that is the plan for today. And at the very end, we'll talk a little bit about what the next steps are for the work group after we conclude the final meeting. For today's, we're going to look at a lot of data today. And I just wanted to say the caveat that for today's data, all the data that's presented by Hospice Analytics includes only Medicare data versus any data that's shared for the hospice survey includes all payers. So if there's a little bit of a discrepancy in the numbers or things don't line up quite right, that's probably what accounts for that. So just a little disclaimer there. Hospice Analytics was very generous in being able to share some 2024 data with us. It's part of a bigger presentation that they're planning on presenting at the Hospice Network conference coming up in November. But we have a few slides today to help facilitate this conversation. So everything that says Hospice Analytics on the bottom is from them. And I'm going to let Cord start by walking us through the 2024 demographics and hospice utilization.
Great, thanks so much. So this is part of a state report that I pulled together for Peggy, and we'll be presenting part of this at the conference coming up in November. The 2024 calendar year information from Medicare is recently available. And so this is a slide that I pulled together and encourage people to just print this one off. It just has some statistics that are helpful if you're writing a grant, if you're answering questions from a reporter, Department of Health and CON types of conversations with population and death information, number of Medicare beneficiaries and beneficiary deaths, state compared to national. There's a couple of things that I highlight on this slide. One is in bold, about 2/3 of the way down, the hospice utilization rate. So the percentage of beneficiaries who die that die on hospice. In Maryland, that's about 47.7% compared to national at 50.6%. The piece that's kind of interesting right now is as we're rebounding coming out of COVID, that national utilization rate's the highest we have on record. It just barely exceeds the 2019 rate. So we're kind of back moving in the right direction as we would expect. For Maryland, it's the second highest rate, second only to 2019. And next year, I expect both of these are going to go up about 1 percentage point and be the highest on record again. So that's good news. We have total days of care and the mean and median lengths of stay, where you can see the lengths of stay in Maryland are substantially shorter than the national average. And tied to that are the last couple of lines, the total Medicare expenditures on hospice, and particularly that very last line, where because of that short length of stay in Maryland, the mean reimbursement per beneficiary is substantially lower than the national average.
Thank you. So with the aging of the baby boomer population, the population is continuing to get older and increasing in the number of deaths, and that's expected to continue through 2055 at least. So the question is, how can hospice work better together with the acute and subacute providers to ensure patients are receiving the right care at the right time? As Court pointed out, the national utilization is 50.6%. Maryland, it's a little lower at 47.7%. And the lowest nationally was 46.7%, but rebounded to 50.6%. We also want to point out that Carroll County tends to have, actually very consistently has the highest utilization rate. In 2024, it was 62%, and the lower utilization rates tend to be in Allegheny, Garrett, Prince George's, and Somerset counties with a range of 29 to 40%. So there's a few more graphs
Hey, Stacy,
Yes,
have we, those same counties, have we graphed those over time? And has there been any improvement? And if it's coming, I apologize. But I'm just,
we do have that information. I don't have it with me right now, but we have graphed those over time. Let me get back to you.
thanks so much.
So we can stop here and discuss, or we can continue with a couple more graphs and then discuss. Let's have Court discuss the next two graphs.
So this chart is taking a look by state and just sorting them by state on hospice utilization rates. As we discussed, Maryland is a little bit lower than national average, ranks 37th across all states. Utah is the highest. It has been for several years in a row. Right now, it's kind of right there at 60%, which is really about as high as I would expect a state or a national level to be. So they're pretty cutting edge there. And then New York is the lowest state at 27%. The piece that I would kind of mention here, I'm in Kentucky at the moment, getting ready to present at their state conference tomorrow. Kentucky's also certificate of need. And I put arrows on the 16 states that have certificate of need for hospice. And it's interesting to see how it lines out because when we talk about utilization rates, it's about half of the states with CON are above the national average and half are below. Kind of indicating that the presence or absence of CON, or even the methodology and how it's implemented, is perhaps not the biggest driving force, which we'll see in a couple more slides when we look at Prince George's County and Baltimore City. Over time, there seem to be other factors that are influencing it, but I am taking a look at those 16 states and seeing things like quality measures tend to be higher in CON states compared to non-CON states. Utilization is about the same, and length of stay is substantially shorter in CON states. So it's just kind of interesting to think about the trends and what that looks like from a CON perspective. But that's it for this slide. Thank you. This is breaking it out by county and taking a look from highest to lowest hospice utilization rate. Again, calendar year 24 information just last year, and then highlighting where the state and national averages are.
Okay, let's pause here. Do we have any feedback on some of the questions, some of the utilization rates, and how post-acute care can help hospice?
Hi, Stacy. This is Amanda from the Maryland Hospital Association.
Hi.
Can you all hear me?
Yes.
Thank you. So I had proposed these questions to some of our members, and they had shared that there were maybe some areas of opportunity where they felt a multi-pronged strategy could be initiated to improve not only communication, but education between the entities. And so they've listed out a few recommendations, and I won't go into detail of all of them, but I'll highlight the few recommendations that they made. One was embedding hospital liaisons within care centers, so such as nurses, social workers within those areas. Standardizing shared decision-making across transitions, so utilizing shared document tools, clinical triggers for prompt, timely consultations. Investment in cross-training and education, so acute care teams doing education about hospice eligibility, and then to dispel some of myths associated with it. Other recommendations that they had surrounded addressing some systemic barriers to access, improving flexibility and communication coordination. So those were some notes that I received from the field over the few days. Thank you.
Thank you. Dana, you have your hand up?
Yes, thank you. Similar to what Amanda just said, I did also pose these questions to some of the lifespan nursing home members, and I received pretty much the same response that Amanda just mentioned, and that was really just the need for additional communication and education between hospice and the nursing homes, especially post-COVID, kind of almost needing to, I know that there was a lot of education done prior to COVID. I think that needs to be almost repeated, it sounds like, from what I was reading from the membership, just needing to really understand the way that hospice can and the nursing homes can work together, how staffing works, given the fact that when a patient does or a resident does go on hospice, the hospice becomes primary. So that was some of the comments I received, just almost a better education, especially since we also have had so many childs in the industry in the last few years. The need to just go back in and really partner up again.
Thank you. Kathy Hamill?
Yeah, I think our biggest issue is actually a payment issue. Hospice house beds are not paid, room and board is not paid for Medicaid, but we pay for it in nursing homes. So one of our opportunities is, why would a hospice house bed not be eligible for Medicaid room and board, where people could leave the hospital and receive, and right or wrong, nursing homes have limited numbers of Medicaid beds, right? They don't want to fill their entire institutions with Medicaid. So that's one issue. I think the second one is we see 20% of our referrals. So I would say, Amanda, in some ways, the acute care hospitals, because many of us have liaisons in the hospitals, are identifying patients, but people don't want to pay room and board. And when you're in a long-term care bed, so we either send them for subacute services, which are completely inappropriate. We're taking hospice eligible people and putting them in skilled nursing beds. That is, from a resource perspective, bad for patients, but people don't have money to pay room and board for long-term care. That is our biggest barrier. But 20% of our nursing home referrals don't get moved to hospice because of the room and board issue. The third thing is that I believe we are one of the highest states, at least last time when I was serving on the nursing home committee, we have the highest length of stay in subacute in the country, one of the highest. Other states are incented to keep that length of stay in nursing homes down in the 10 to 15 day range. We're almost at 22 days. So our stays are too long and they're not appropriate for hospice, but we need to change the payment system, not the least of which is Medicaid, just making the hospice houses eligible, or hospice house beds eligible for Medicaid reimbursement directly. I would also say that, it is a drain on hospice organizations to have to process the room and board in nursing homes, and for the nursing homes to wait for payment. Right or wrong, there's a delay the minute you add a third organization. So a lot of this is structural that I believe we can fix. It is less about identifying in some ways, like literally we would pick up 20% of our current referrals by moving those other barriers. So there are a lot of patients that aren't getting the right service because of payment barriers. So I would strongly urge us to think about how we do that. And if we eliminated the room and board pass-through and just let the nursing homes bill directly for Medicaid room and board for a hospice patient, we would save administrative costs in the hospice, and the long-term care facilities would be much happier controlling their own destiny. There's a potential risk, right? Because it was designed initially because there were concerns that the nursing homes would stop using hospice completely, but maybe we could do a pilot in a couple of locations and see if that were the case. But those are our thoughts on the subject. And I apologize that I did not send them in advance. I just was out on vacation, so sorry, but something.
Thank you.
Yeah.
Brandon Rose?
Hi, I actually was going to take my hand down because Kathy said it perfectly. So I just echo what I will echo what Kathy said and just add to it. It's I really believe this all comes down to education for the administrators and the frontline staff in the nursing homes. And there is just such a stigma around the hospice care that can be provided, and that added quality for the patients in the nursing home. And circles back to the previous speaker as well. It's about the stigma of hospice, and we experience that even at the nursing home level. So just to keep it short, thank you, Kathy. I think that was very well stated.
Thank you.
Monica?
Yeah, I too appreciate what Kathy said, and I have a little bit of data to sort of make Kathy's argument for discharges inappropriately to nursing homes. If you look at the time that it takes the hospital to discharge to the post-acute facilities, you will see that it's higher than other parts of the country. And if you look at it, was just looking at it for Prince George's, it takes longer because it's a placement issue, and the hospital staff is trying to find a place that will take these patients. If we had room and board in our inpatient units covered by Medicaid, it would be a game changer. If we were not processing room and board for nursing homes, we would have even more referrals than we have right now. So I really love what Kathy brought up, and I was just going to offer that the analysis of Medicare claims can also provide information to support that.
Thank you. Sarah?
Hi, I just wanted to add to kind of what Kathy and Monica were saying is the other issue that we're seeing is if a patient's, let's say in the hospital or even in the home, and they need long-term care and they qualify for Medicaid, a lot of the facilities will not take those hospice patients because if they die within 30 days of applying for Medicaid, they don't get reimbursed because it doesn't retro back for them. So that's another struggle, and where if we could help support, for us and especially with most of us on this call being not-for-profits, being able to take those patients to the inpatient unit, also knowing that there's potential for payment there, we can get those patients the appropriate care, and they're not having to choose potentially skilled care when it's inappropriate for them just because they don't have the ability to pay.
Tina Simmons?
Hi, thank you. I just wanted to echo as well what Amanda shared about the education, and just to share with this group that HSCRC has a program called New Paradigms that is provides funding for some pilot programs. And so one of the programs that is getting funding this year is for expansion of palliative care and hospice education for providers in acute care facilities specifically. So that's a collaboration that some of the hospitals across the state with Gilchrist and GBMC. And so my colleague Krista will share more about that, I believe, in our September HSCRC meeting. So that need is very well noted. And so there are some plans to hopefully expand education moving forward. And then I also had a question for this group because I know we're discussing collaboration with nursing homes and home health, et cetera. But is there any formal collaboration with primary care? Because I just wonder, with the front end opportunity, the utilization figures that were shown as far as like the time spent in hospice, if we were partnering with primary care, you know, potentially getting patients in earlier, maybe they would have longer utilization, and we might see a shift there. So people avoiding hospitalization potentially.
Yeah, I also think, Tina, to piggyback on what you're sharing, I think cardiology, pulmonology, and oncology are also specialty areas that we could move that relationship, because so many of them stay with the specialists and don't go back to their primary care. So thank you for that. And I think there's also one other pilot going on, which is the advanced care planning in nursing homes specifically, right? I think in Frederick, if I'm remembering correctly. So two hopefully strong pilots to share some results and data.
Thank you. Dr. Rose?
Hi, thank you. I do feel that some of these points we did discuss briefly in one of the previous work groups. So I just want to raise this again to make sure that it meets the platform for discussion. One of the key challenges that I have in the nursing home with hospice patients as an administrator is this GDR for hospice residents. And balancing the regulatory compliance with quality of care. My hospice patients often have complex symptom management needs, you know, particularly for pain and agitation or anxiety. So the pursuit of a GDR can risk destabilizing comfort and dignity at end of life. And this is one of the things that, you know, as far as receiving pressures from surveyors to reduce the psychotropics. But in hospice, you know, our clinical focus is to remain on, you know, honoring the patient-centered goals. So I think there needs to be some discussion around the compliance issues for the GDR efforts, which just seem highly, they just inadvertently compromise the quality of care, and it undermines the whole concept of comfort when we're trying to manage symptom control.
Thank you. Patrick O'Malley?
Yes, yeah, I guess, so I'll represent the home health side of that. And I heard your comments, Kathy, about the nursing homes, and certainly I'm empathetic to that. But when we look at, for us, we get a lot of folks discharged in the home health world out of hospitals and skilled nursing facilities that are coming out sicker and sicker. And with that, we're also thrust into the conversation piece of whether this is traditional home health or is this more of a hospice. And so I really advocate for stronger alliances between home health agencies and our hospice agencies. We've found internally that we can actually improve our quality of our care that we're delivering by making sure the clients stay safe at home or transition to the right venue. And so I would just be remiss if I didn't advocate a little bit around the strengthening of the outside of the walls of the institution, but more into the home, and how can that help increase the quality of services for our Marylanders.
Well said.
Thank you. Let's move on to a little more data for you. This slide shows you a little bit more about the mean days of care from 2016 to 2024. So this shows that the mean days of care nationally has gone up steadily over almost a decade, but in Maryland, it has not changed much. So that is something that I think we're all working on. And the next slide is for court.
So this slide breaks hospice length of stay into different categories that have historically been used by the National Hospice and Palliative Care Organization to think about length of stay in terms of less than a week. What I would emphasize with this slide is you can see nationally about 51% of hospice mean length of stay is under a month, while in Maryland it's about 60%. So a much higher percentage of patients with shorter lengths of stay in Maryland. On the opposite end of that discussion, you can see the lengths of stay 180 days or 6 months and greater nationally at 14% compared to Maryland at 9%. So many more short length of stay, many fewer long length of stay patients is giving those averages for Maryland having a short length of stay. Another piece to comment on from a national perspective with this is when you look at states like Texas and California, their mean length of stay in hospice is about 99 days. And there's a proliferation of new hospices in both of those states that are accounting for a lot of long length of stay in hospice in ways that I will judiciously say Maryland and other states don't want to replicate that. Like, we want a longer length of stay, but we want it clean and appropriate and according to the regs. So the last slide, you could see some of the ups and downs in lengths of stay through COVID nationally and in Maryland. And in general, what happens is Maryland is following those national trends. When national goes up, Maryland goes up a little. When national goes down, Maryland goes down a little. It's just Maryland has a bit more stability in that length of stay. The changes are more incremental, where nationally we're seeing some of that unusual activity in California and Texas is actually driving national numbers.
Yeah, Court, I was going to ask if you looked at the number of hospices that hit the cap nationally versus the number of hospices that hit the cap in Maryland. I think that speaks to what you're talking about. So
yes, it would look exactly like you think it would.
Yeah, like 0 to a lot, right?
Exactly right.
Okay. I think that's a really important consideration for the state. I don't think you want us hitting the cap. Do we know that number, Court, nationally? How many hospices hit the cap?
I'd have to take a look. I've seen, for example, Palmetto, MAC have released those numbers on a quarterly basis. So I'd have to take a look. But when I do look at those numbers are largely driven by long lengths of stay because the vast majority, like 97, 98% of hospice is at the routine home level of care. Sometimes we talk about hospices getting close to the aggregate cap because they provide more high acuity care, more care at general inpatient or continuous home care. But really, that's such a small percentage of the pie from a reimbursement perspective. Length of stay and how many days are billed at routine home is really what drives hospices getting close to or exceeding the aggregate cap. And there are some providers nationally that are very skillful in staying at between 95 and 99% of the aggregate cap.
Yeah.
From an average reimbursement perspective, while hospices in Maryland, in other CON states, and just a lot of hospices across the country are so far away from even getting close to the aggregate cap. Like they're not losing sleep over paying back the government for exceeding the aggregate cap. But there are hospices, particularly California, Texas, Arizona, Nevada, that are weaving that line very closely. You're right, Kathy.
Thanks, Court.
Okay, I'm going to switch topics just a little bit and talk about special populations. So should we consider CON applications for hospices that want to work with special populations if they can demonstrate a need? So in Maryland, over the past 10 years, the population of Maryland has changed, and the representation in hospice has changed proportionally. So the number of white Marylanders represented in hospice has decreased over the years, and the number of people who identify as multiracial has increased over the past 10 years, and the people who identify as African American or Black has remained pretty steady over the past 10 years. And also for people who identify as Asian has maintained steady over the years. At the past 10 years anyway. So, report has some data on, this is Baltimore City.
Yeah, and just Stacy, maybe a comment about the previous slide. When I was looking at that and thinking about that, the context for interpreting that information in my mind went back about 25 years in hospice, when we saw percentage-wise a decrease in the percentage of hospice patients whose primary diagnosis was cancer, and an increase in cardiac and or cardiac disease and neurological diagnoses, that sort of thing. And the way we interpreted that at the time was, we're not taking care of fewer cancer patients, we're increasing the amount of care across other diagnoses. And that's actually kind of how I thought about the racial balance in that last slide. Is it's not necessarily that white care is going, care to patients who are white is going down, as much as it is care being provided to people with multiple racial backgrounds or Black backgrounds are increasing. So, I mean, I get 100% is 100% and we have to divide it up, but that's how I tend to think about it racially a little bit more. When we look at this slide, looking at Baltimore City, and the next slide's looking at Prince George's, the utilization rates, you can see the steady increase from 2005 to 2019, and then COVID hits. The very top line is US, the middle line is Maryland, and then the bottom line in this case is Baltimore City. That's that COVID dip. Similar explanation. It's not that hospices were taking care of fewer patients. It's that during COVID, so many more people were dying outside of hospice, primarily in the hospital setting and probably at home, that's why hospice percentages went down, even though the numbers of patients we were serving went up. There was such an extraordinary number of unexpected deaths about 2020 to 2022. I put the line there for 2019 actually not to represent COVID, but because I think that's when, according to Maryland CON, there was an additional hospice or 2 licenses that were put in that were allowed in 2019. And again, as I reflect on looking at this, just the data perspective, and the folks on this call with the boots on the ground perspective can refine this statement, but these changes in utilization look more to be driven by COVID and following national and statewide trends than adding another hospice increased or decreased utilization in this particular, in this case, Baltimore City.
What's the reference to plus 20.1%?
That's the percentage growth from 2005 to 2024.
Thank you.
So Maryland as a state has grown in utilization, and Baltimore City here has grown as a specific area faster than the national average.
Thank you.
The next slide, all the same explanation, but for Prince George's. This slide is a way I've been thinking about the racial diversity and the mix in hospice. And the way that I pulled this information together was looking only at beneficiaries who died, identifying beneficiary race, and then dividing it by if that person died in hospice or outside of hospice. So if we could, gosh, Stacy, I'm on a laptop, so is that Maryland died with hospice? Is that 79%? Thank you. 73%. So we're saying in this slide that 73% of Maryland Medicare beneficiaries who died were white. And all things equal, like we would think 73% of those who died outside of hospice were white. But they're not. It's more like 60% instead of 73. And there's that question about a 13% gap. Like, we know all things are not even across provision of services by race, but this is looking at that difference of people who died in hospice versus outside of hospice. When you look at the national, there's a 9% gap there. And I put this slide in the context of the racial diversity of the state. Maryland has a lot of racial diversity. The most racially diverse state, Hawaii, because of the Asian influence there. When you get into states like Maine and Minnesota, there's so little racial diversity that it kind of shapes how this slide looks. But the point is just thinking about how can we raise the percentage of beneficiaries who are dying in hospice, particularly among Black, Hispanic, Asian, and other groups, and seeing that level out. I think there's a comment at the bottom of the slide that says this is improving, meaning nationally and in Maryland, that gap nationally, the gap used to be 11%. Then it was 10%. Now it's 9%. It's improving, as Maryland has over the years as well.
Okay. Before we turn the conversation, did anyone have any comments about that before we turn the conversation back over to Medicaid?
Hi, this is Amanda again from the Maryland Hospital Association. And from a member perspective, I think it's pretty safe to say that many of our members do have concerns or broader concerns surrounding certificate of need. The feeling is that Maryland is usually strict and limiting and have capacity for post-acute services. And that the bed capacity is very limiting for Maryland within these settings, and that the lack of license in inpatient hospice bed capacity means that patients have limited options for receiving hospice services for their end of life. So any opportunity for the state to look at any portions for certificate of need modification, I think would be greatly appreciated.
Okay.
Amanda, can you repeat what you said about inpatient beds? We can't hear you.
Sorry, Kat. I lost my notes, so give me a second and I'll find them again.
Okay.
So the comments that I have here speak to Maryland having a heavily under bed across all post-acute care settings, including inpatient hospice bed capacity. The certificate of need in Maryland is unusually strict and limiting and has dramatically limited capacity for post-acute services to improve care transitions for hospitals and accommodating the unique care needs for patients. So the sentiment that was shared with us was that the bed capacity is very limited in Maryland for inpatient hospice, acute inpatient, rehab, long-term care, and skilled nursing facilities, which then the lack of licensed inpatient service beds means that many patients have limited options for receiving hospice services at end of life. And then some of examples that were cited was that patients may receive hospice services in assisted living communities. However, many patients cannot afford assisted living. So receiving hospice in this care setting is not a viable option for many patients. Another example that was given is that patients that are at near end of life can't safely remain at home to receive hospice services in their home environment, and hospice companies that do not provide 24/7 support in home. If a patient does have to have an adequate support from family or cannot afford private duty home health aides, then there's an argument for home health hospice services that are not a valuable option as well. So those are just some comments, and I don't know if Kathy, if that addressed your question or not.
Yeah, actually it did. I just want to go on record that we actually closed 10 beds for inpatient coming out of COVID because we can't fill them. So again, I think there's been a significant change in CMS's interest in inpatient and the amount of audit activity. I think it's more a policy issue than it is an availability. We would open those 10 beds in a heartbeat if we had qualified. And I think what you're speaking to, Amanda, is that we're seeing many more patients at a routine level of care. To Patrick's earlier point, the acuity level is going up, but those patients still don't qualify for inpatient and actually need residential beds. We are funding a 22-bed residential facility at the tune of $3.1 million a year in losses and subsidies. The routine level of care for room and board is a problem, and we don't have a good, Maryland, the nation, don't have a good policy for alleviating that problem, and the expectation that an 85-year-old spouse will be the sole caregiver for their 85-year-old, husband or wife is not a durable solution. And this is, in our opinion, this is only going to get worse. So finding a way to pay for room and board, Medicaid is one suggestion. But yeah, people who can't afford assisted living and other options, we don't have good alternatives for them. But not for lack, I just want to kind of go on record, not for lack of trying, but there's only so much subsidy that we can, provide for these beds that are unbedded. We do have a couple of hospitals who are leasing beds from us because they need the throughput in the hospitals. And we would certainly be interested in partnering with others for that type of solution.
I wanted to also interject too in reference to something Amanda said about the strict and the limiting in terms of the CON. CON has, since 2019, there was a change. CON is not involved at all anymore in general inpatient hospice, not involved in the creation of and increasing beds and decreasing beds. CON is completely uninvolved in that anymore and has been since 2019.
Thank you for that.
Carlos?
Yes, hi. I just wanted to chime in actually to share the same point of view that Kathy just shared. It's not an issue that hospice has insufficient beds or bed capacity within patients. It's misalignment of the payment systems that Kathy mentioned earlier. We have a huge number of patients that we care for at a routine level of care every day that we're taking a significant loss on, simply because we're trying to do the right thing by the patients. If Medicaid were able to provide for room and board, that would be alleviated, and we'd be able to take a lot more patients, provide them the proper level of care, and really help out our hospitals, Amanda. So it's not an issue that we don't want to, it's that we simply have limits in terms of our capabilities to absorb these constant losses.
Now, I appreciate that both Carlos and Kathy, that was a concern that some of the members had raised related to the bed rate costs and how some of that is pushed back onto the family members. And again, speaking to financial burden during their time in which they should be spending with their family and loved one and helping them pass, but then dealing with a financial burden. So that's definitely something that the field has also noted as a concern.
And I would just add that, we're concerned about the minority communities and expanding care. These are the same communities that are most often impacted by the inability to pay for room and board rates in long-term care facilities, and the ones that are in most need of hospice support. So, I could significantly increase the number of patients we're caring for on a daily basis if that were not the case. Because too often we have patients who are saying no to hospice simply because the room and board is complicating their care.
Yeah, this is Steve. I would just echo everything that Kathy and Carlos have said. We have 2 facilities on the 4 counties in the Lower Shore, and we have plenty of beds. But it's the financial aspect, particularly what Carlos is talking about. So there's no shortage of beds on the Lower Eastern Shore.
Okay. Great discussion. Thank you. So let's bring things back to talking about Medicaid. And I know Leah is on the phone with us. And Leah, bunch of Medicaid has come up over and over. I'm sure you have all the answers for us, right? But just in terms of the Medicaid pass-through, I do have a little bit of information here on the slide, just in case people aren't familiar with what the pass-through is. Curious, does anybody in the hospice community know? So this is not just a Maryland thing. It extends beyond Maryland, but there are states, I believe, that have overcome this or put things in place to kind of get around this. Does anybody know of any states and what they've done other than Maryland?
Delaware.
Delaware.
Delaware?
I actually have a small hospice in Pennsylvania, and Pennsylvania does not do the pass-through. It actually has made it a lot easier for the facilities as well as the hospices because it doesn't overcomplicate the billing aspect of it, and it does allow for the facilities to directly bill. They're able to get their money a lot quicker, which eases the financial burden on their end, and they're not waiting for that third-party intervention, as Kathy was stating earlier.
Okay. Dana?
Hi. We looked at this a couple years ago, and I have a memo I'm more than happy to send to you to take a look at. When we looked at it, and like, for example, that I think it was the District of Columbia tried to do something, then they ended up having to rescind their memo. I think the states that were able to do it also had, it was managed care. They had implemented managed care, and they were able to do it through those programs, but not on any type of fee for service. But I'll probably needs dusted off, but I can send that to you. But we did a pretty extensive look into it a couple years ago.
Okay, that would be great, Dana.
Yeah,
Thank you.
because I know Wisconsin is coming to my mind that they had done something with it. But again, I'll dust it off and send it over, Stacy.
Thank you.
Peggy. Peggy?
Thanks. Yeah, so Peggy, and again, I'm with the Hospice and Palliative Care Network of Maryland. So this is something we've actually been looking at for years. And I can tell you it's not just a Maryland state issue, it is a national issue. If we could do something here in Maryland about this, it would just be terrific. But a couple of states, I believe Virginia does not have it. They got around it through some kind of budget legislation in that state. And I agree, I think Wisconsin as well. And I'm happy to send you some of our information as well. Unfortunately, this is in federal statute. However, because Maryland is a waiver state, I do wonder if there isn't a way that the HSCRC could not help us get around this. Something we've been asking for a very long time.
Okay, Monica?
I know that the state of Delaware has found a way to not have the hospices process these pass through. And I know that the year they did that, it's been a long time. So probably 10 years that they have been had this practice. And I remember it being correlated with increased utilization, because there was a point in time when Delaware was the second highest utilization statewide of hospice care. So just that piece of information.
Okay. Court?
I would just echo what Dana and Peggy said around taking a look at Wisconsin. I'd also add Illinois to the list.
Okay. Dana?
Yeah, and actually, I'll also send a letter. So the Hospice Network in 2023 sent a letter to the Maryland Healthcare Commission, Dr. Sharfstein, asking the Maryland Healthcare Commission to work with the HSCRC on this. And basically, we were told no. But I'll send you that letter. It has some also information about the federal requirements.
Okay, yeah, that would be great, Dana.
Thank you, Dana.
Dana, was there a basis for the no?
Trying to remember. To be honest, we didn't get anything in writing. It was that we have other,
Okay, so it
we had
wasn't
other
like,
issues, basically.
so it may not be a no, it may just be a not now.
Well, they never responded, actually.
Yeah,
No.
so it was through conversations we had.
There is a
Hi,
lot
so
going
this is,
on.
sorry, this is Tina. I made a note. I copied this slide, so I'll follow up with John. I think there's some regulatory component to this, but I don't want to misspeak from limited knowledge, but I put it on my list just so I can tag John and follow up.
Awesome.
Thanks, Tina.
You're welcome.
Thank you.
Okay. So discussion questions with Medicaid continued. If you look at the pie chart here, we can see that Medicare is 86%, Medicaid 5%. These are national numbers. So nationally, Medicaid is at 5%. So a discussion question is, why does hospice in Maryland have a lower utilization of Medicaid patients? So in Maryland, according to the survey data from the hospice survey, it's approximately 2.6% compared to the 5% nationally. So does anybody have any thoughts about that question? Monica?
I have a question. When you use the term discussion of Medicaid funds, is this including room and board, or this is for straight hospice payment?
This straight hospice, like overall.
The room and board is not part of this. Those
No.
numbers. Okay, great. I think it speaks to the fact that when there's placement issues, everything that we've been discussing is pretty much the result of not having our inpatient units being an alternative to acute care when patients are appropriate and being reimbursed by Medicaid. I think that would be a game changer, because a lot of these patients are going to rehab centers when they are actually dying because they can't afford their room and board any other way. That's my thought.
Okay, thank you.
Is the percentage of Medicaid in Maryland the same as the nation?
Maryland is 2.6%. So about half.
Right, of hospice. But in general, is the percentage of Medicaid in Maryland higher or lower than other states? Or is it a mixed bag?
I'm not sure, but I can look into it and get back to you, Kathy.
Yeah, I'm just curious whether we just have, we choose to use our Medicaid dollars for different, right? Once we get to the state level, there's all kinds of variation as to what's covered and what's not under the Medicaid program, I would think. Because the state has some jurisdiction over that, but room and board is certainly a barrier. And then we talked earlier about just the, our overall length of stay in nursing homes is longer. And that's a covered service under Part A.
Okay, so returning the conversation, go ahead. Does someone want to say something? Okay. Turning back to emergency department wait times. Tina, I know you're here on the call with us. Is there anything that you didn't get to, I wanted you to have the opportunity to talk a little bit about your work group and what you've been working on with the emergency department wait time. So is there anything that we haven't brought up that you want to mention about goals for what you're working on?
No, I mean, I think you hit it. I mean, the only other area, as I noted, that we are exploring is, I know it's a passion project too for Dr. Morheim, who is on there, is, we are looking at opportunities to really focus awareness on advanced directives, advanced care planning, so that we can forge some partnerships with kind of that front end to prevent some of these patients from getting into the hospital. But we are really focused on the care transition piece from the acute care patients to skilled nursing facilities primarily, but looking at options of patients who could go to hospice instead of skilled nursing. And so I think all of the information you guys have shared has been incredibly helpful into some of the barriers that we will make sure that we highlight when we put out our recommendations as well, because we have noticed that there are opportunities, I think, for patients who could potentially transition to hospice instead of skilled nursing. And for all the reasons that you've noted, that doesn't happen. But from the ED perspective, again, the reason why that's important, that care transition delay, in analyzing our data, we see a significant across the state about 7-day increased length of stay and inpatient length of stay for patients who have to go to some facility. And so that kind of contributes to that ED boarding situation, which impacts the overall wait time. So thank you all for this information. It's been incredibly helpful.
Tina, as you were talking, I'm wondering if the 3-day, part of the reason that we have a 7-day length of stay is the 3-day requirement for placement, and whether we, part of the reason that they move from the ED to an admission is to meet that 3-day length of stay. And I'm wondering if we could, during COVID, we waived that. And that was not the time to measure whether people were going to increase their hospice utilization, right? Because there were all kinds of other issues. I'm just wondering if, again, either on a pilot basis or systemically, whether lifting that 3-day requirement. And there are states, I understand, don't know anything about them, but who have lifted that 3-day requirement, and wonder if that increases hospice referrals.
I'm making a note. With definitely, I think it's something that we can look into.
It's another payment barrier, because I'm not going to go to a long-term care bed because of the room and board issue anyway, but then we get another 3 days in the hospital waiting to qualify for the Part A stay. So we get inefficiencies in both areas. So just
thank you for that.
Sure. The next slide. Oh, Carlos.
Yeah, I just wanted to add that, I understand the challenges in the ED, working as part of a health system. I hear it from our ED departments all the time that this is a significant issue. And I'm always asked, why aren't the primary care providers in the community having these conversations? Why is it always, left up to the ED physicians in the hospitals to have these conversations? And it's really a valid question. And, part of it, I think, is, again, misalignment of incentives. There is no incentive really for physicians in the community to be having these conversations. Their time is very limited, and these conversations take a great deal of time. So it's no surprise that we're at this crossroads. And what you end up seeing is a cycle of patients that don't have these conversations appropriately. They end up in the hospital having these conversations. And obviously they're pushing back because it's coming as a surprise to them. They're thinking, why hasn't my physician told me these things? And they end up being discharged back to the community, and the cycle starts all over again until they need another admission to the hospital. So I don't necessarily have an answer. I think that in some respects, we need to better align the incentives of the physicians in the community and their payment structures in order to reinforce the need for these conversations to be had earlier. If we can do that effectively, I think you will see a change in these dynamics and behaviors, and hopefully fewer of these patients will end up in the ED, and more of them will be referred appropriately to hospice early, so we can avoid a hospital visit altogether.
Yeah, that's actually a comment I have made in other forums as well. Prior to joining HSCRC, I worked on the healthcare side, and actually I was involved with programs, primary care programs, Maryland Primary Care, and then Delaware Primary Care First. And so the Delaware Primary Care First program actually does have metrics in there that are tied to incentives for advanced care planning. And so I think that would be something kind of as a future state goal. I completely agree with you to see, how there are ways that we can work that into incentives out in the community for Maryland. So I fully agree.
The other thing we might consider is we have noticed that there are quite a few patients in the ED that are actually sent by the nursing homes.
Yes.
And on a good day, when we can really stop and call the nursing home, in many cases, they're not wanting the patient admitted, but they do want them evaluated with some recommendations and sent back. We did a pilot at one point where the nursing home would send us, please don't admit, we just need an assessment but it's very intense, it's very difficult to execute because we're on different EMRs and the communication is difficult. But again, there might be a way to do some partnerships between, many hospitals have, I won't call them preferred relationships, but because of the geographic reach, there are certain nursing homes that they work more with than others. And maybe there's a way to craft that communication where we decrease the amount of admissions, avoidable.
One of the other suggestions that I have received as well is exploring further the telehealth programs that some of the EDs have, so that sometimes the patients in the nursing homes can be evaluated and care can be coordinated, and that transfer to the hospital never even has to occur. So there are a number of hospitals that have a program like that, and so looking at potential to enhance those programs is also a suggestion that we've received from a number of stakeholders.
Thanks.
Thank you. Thank you. Thank you, Tina. Okay. Just a couple of questions that sort of fell underneath the category of other. I wanted to bring up the hospice survey and currently we have 26 hospices in Maryland, general hospices, and then we have 25, and then we have one limited hospice. I wanted to sort of talk about the idea about data collection for the hospice survey and whether or not we should continue to include the limited hospice in our data collection, and see if anybody had any thoughts about that one way or the other. Hi, Monica.
I would advise against including the non-medical hospice in the data because it's so different from what the other 25 do. A non-medical hospice is purely a volunteer program, whereas you're not comparing our volunteer programs with their volunteer program. If we are putting all the data together, we're considering an non-medical hospice, and the majority of what we do is medical. So I would recommend they are a category of their own.
Okay. Thank you for that.
Yep.
I also wanted to bring up briefly acquisitions. We've had a lot of influx in the state, especially with nursing homes and increases in private equity acquisitions. I'm not sure that that has really hit the hospice community yet as hard as it has in nursing homes, but it could be something that could be in the future. So wondering about when we work on this chapter, is there something that you guys would like to see? There is a section in the chapter on acquisitions now. Is there anything you guys would like to see us add there in terms of acquisitions that we could be looking at or that we would add to the chapter?
In all honesty, I've not read the chapter, so I could be making a redundant comment, but I think what we learned from the nursing home acquisitions was that understanding the ownership, the transparency in ownership. And again, maybe that's already in there, but I think we, if not, we could potentially lift what the nursing home group learned and make sure it's in the chapter.
Right. And what about the idea of maybe having them self-identify as private equity if they are a private equity firm who's doing the acquisition?
Yeah, I agree with that. You know, I will say that some of these corporate structures are so complicated that they feel like they can answer the question that they're not private equity, even though there is some private equity. I'll defer to my colleague Court for, you know, what's going on in the West. So whatever we have to do to try as best we can to understand where there is private equity, that would be great. Thanks.
This is Cord. I would certainly agree with that. I'd say I've spent several years trying to understand and identify the prominence of private equity in hospice. Right now, I would say about 17% of hospices nationally are owned or have substantial private equity funding, but that's really, really muddy and difficult. And I would go so far as to say many of them purposefully make it difficult to find out that information. It's really been interesting looking at it. There was a couple of JAMA articles that came out in 2021 about the influence of private equity in hospice that has spurned a lot of folks looking at that, and me among them. So in terms of asking any new providers on the application if there's private equity funding, I agree with that. Asking existing providers on an annual application, you know, kind of the renewal, I would encourage asking for that. And in terms of your specific question, is there a 3-year rule for no changes to discourage any kind of private equity flipping? I would encourage that as well. Again, not based on experience in Maryland, but in other states around the country, this has become a growing concern. I will try to balance out my comments, my concern around private equity to say, I've also seen some research studies. We're working on one in hospice. I've seen it in home health that simply suggests private equity ownership increases business efficiencies, and they will state that the level of quality does not decrease. They're not saying it increases, which is maybe a concern, but they're saying that it does not decrease. And so that there is some literature out there to suggest a keen business strategy that is okay and kind of innocuous. I think there's concern that there might be more problems with decreasing staffing so you can increase your revenue and for sale and acquisition kind of activity. So we're really trying to unpack that, but the degree that you can begin or continue collecting that kind of information, it sounds like you're doing it in other fields in Maryland. I'd encourage it for hospice as well.
Okay. Thank you, Court. Peggy?
Yes, here, Court. I couldn't agree more. As I talk to my colleagues across the country, especially those on the West Coast, it's a shame they didn't have this, type of transparency in place to begin with, or they may not be experiencing the challenges that they are now. So I would, really thoroughly agree. We should definitely include this.
Okay, thank you. Does anybody else have their hands? Okay. Okay, and then I think the last question that I had on here just had to do with the role of education, and we've talked about that. I think it's come up several times today, but we certainly at the commission would be, willing to continue that conversation about having some education. If we could be helpful, we would certainly be willing to do that as well. Does anybody want to bring up anything else about education before we move on to the next and the last slide? Any specific ideas or thoughts around education?
I might just chime in. This is kind of maybe a historical comment more than current, but the state of Maine really took on an education role around hospice utilization several years ago. They partnered with their School of Public Health in Portland, Maine, and really did a remarkable education job that has increased their hospice utilization rate, second only to Alaska of all states in the country. So very rural. I know there's a different dynamic there, but I would just highlight that to say that yes, education can make a positive impact on utilization rates.
Okay. Anybody else, Joy?
Peggy.
She put her hand.
Peggy. Yeah, so I would say, I just want to say I agree. I think you can never have too much education, certainly. But I also think it would be really nice if there could be some funding allocated from the state that really gives us the opportunity to do the high-powered education that we would like to do. I know that our members on their own do tons and tons of education within their community, and really who to do that better than the people that live there and serve the area. But it is expensive, and it takes away from staff time. It takes away from their time. Even to bring in just a keynote speaker, is thousands of dollars. So I would say that rather than see the state even take this on, again, it would be really nice to consider some grant funding for the people that really live and work in these places and, could really do this education well. Just my thoughts.
Thank you, Peggy. Anything else? No. Okay, so the last slide of our last meeting. So the last slide is on next steps. So just to talk just for a moment about what the next steps will be beyond these meetings. So what we'll be working on, Stacy and Vishal and I, we will be working on incorporating the comments that we've received and the ideas we've received from you in the work group into a draft of the state health plan chapter and the methodology. We will develop a draft update of the hospice chapter and methodology. And the first thing that we will do is to share it with the work group and to get your feedback on it. We don't have an exact time frame as to when we will be able to do that, but we will be working on it. I think, with testing some of the methodology, that might take a little bit of time, but we will keep you guys informed as to where we're at with it. We will review and consider the work group's feedback, and then after that, we will distribute a draft for informal public comment. We will review the informal comments and we will revise as needed. And then we will develop a draft for promulgation of the proposed permanent regulations and then present them to the commission for a vote on final regulation approval. Does anybody have any questions about any of those steps going forward? Anybody? Nope, no questions. Okay. Well, thank you guys so much for being here and being a part of the work group. It was our pleasure to be working with you, and we just want to thank you guys for the work that you do. And we just appreciate everybody's time and commitment to this work group. So thank you all very much.
Thank you.
Thank you for the opportunity to participate. We really appreciate it.
Yes.
Thank you.
Great work.
Thank you so much. Bye-bye.
Thank you.
I can't.